So this is the session on national and subnational investigation of the drivers of success in maternal and newborn mortality reduction in India, exemplars in global health. And we have 4 recorded presentations, and we will hopefully have some good discussion after Dr. Bhushan will close and put it all together at the end. Next slide, please. So this work is done as a partnership, which is led by a steering committee in the Ministry of Health, working with NHSRC, IIPS, the University of Manitoba, and the Gates Foundation. And the study is implemented by IIPS and NHSRC, supported by Manitoba and India Health Action Trust. And we also have several international partners that are part of the Countdown to 2030 for Women, Children, and Adolescents Health. And we've been working on this now for more than a year. So hopefully we can present some interesting results today. Next slide, please. So I'll start with a few slides that give you an overview before we go into the contents. Next one, please. So Exemplars in Global Health is actually an initiative of Gates Ventures, which started a few years ago, which really looks at learning from positive outliers in global health. And so there have been exemplar studies in under 5 mortality, vaccine delivery, nutrition. And so now we have an exemplar initiative around maternal and newborn health. And the aim is to comprehensively research the drivers of rapid reductions in maternal and neonatal mortality since 2000 in countries that experienced faster declines than expected. And that means than expected based on their economic growth and other social economic indicators. And so the 7 countries that we are working with, and this is a global team that involves many other institutions as well, are India, Nepal, Bangladesh in Asia, Senegal, Ethiopia, and Niger in sub-Saharan Africa, and Morocco in North Africa. Now, the reason for picking India as an exemplar is perhaps obvious to you all, but major progress has been made in reducing maternal and newborn mortality in the past 2 decades. And even if one looks at the global picture, the share of India in the global mortality for women and for neonatal mortality has declined enormously in just 17 years. India, of course, also has enormous diversity. So this we see as an advantage because the variability between states allows us to further look into trying to understand the drivers by doing subnational analysis. And we'll hear more about that from Usha. Next one. So the way we're tackling it, just very briefly, is as a mixed methods approach, which includes the quantitative and qualitative analysis at the national level, but then splitting it into 2 state groups as well, and then in the 6 states. And the quantitative work basically pulls in all the data sources like SRS, the many types of surveys, million death study, but also global estimates, the National Burden of Disease Study, to look at trends, inequalities, and in coverage and mortality over time, and to look at service and systems data, how that has changed over time. And that's then complemented with qualitative work, which includes an extensive desk review of published in gray literature on policies, programs, and systems, and contextual factors, as well as key informant with senior stakeholders, such as government officials and others. And we'll hear more about that from Kerry as well. So my last slide, which is the next one, is, oh no, sorry, not one but last. And in this study, we basically have identified 4 relevant policy periods. There was the Child Survival and Safe Motherhood Program emphasis in the 90s. Then that continued into reproductive and child health from 97. Then a big step in 2005 was the National Rural Health Mission and more emphasis on reproductive and child health. And then around 2012, that expanded to the National Health Mission and also the broader concept of reproductive, maternal, newborn, child, and adolescent health. And of course, the global Millennium Development Goal and now it's Sustainable Development Goal developments run in parallel to those. The next slide shows then the framework that we've been using to try to identify what drove success. And all the way on the left in the green box, we have the policies and system levers. So these are the things that governments particularly can do to improve the survival of mothers and newborns and also stillbirths, of course. And so levers in terms of money, policies, organizational ways, etc. But the way we approach it is we approach it from right to left. And this is also how it's going to be presented here. So all the way at the right in this framework, which is sort of a mix of several frameworks, including the proximate determinant framework that we use a lot in demography, as well as the World Bank system levers framework and the WHO health system building blocks framework. But we try to keep that proximate determinant framework sequence in there. So all the way at the right, there is mortality. So the survival outcomes that we used in the first place to select India. And Dr. Usha Ram, who is a professor at the IIPS, will talk about the mortality, inequalities, trends, etc. Then the next box to the left, number 3, is coverage and equity. And so here we're looking at inequalities in coverage and how they've changed over time and how that relates to mortality. So Dr. Ramesh from the University of Manitoba will give the second presentation on that. Then we have the very complex middle box, which includes a lot of mechanisms that should operate to increase coverage and reduce mortality, which are very difficult to measure. But some of these, there are good data on trends and how it's distributed. So Dr. Andrea Blanchard will do then the third presentation about that, trying to see what evidence we have of changes in that area. And then all the way to the left, when we talk about policy levers, the macro level contextual factors and the drivers, we'll hear from Dr. Carrie Scott, who particularly has been engaged in the key informant interviews to see what factors are coming up as major drivers of these positive changes over the past 2 decades or 3 decades. And so the emphasis is really about positive public health. And this in global health is not something that we are used to. We're always used to looking at why there are big gaps and why they're not reducing enough, and etc. But here we're trying to identify what was done right to make these big positive changes in India. So with that, I'll end the introduction, and I think we're going to go to, if the technician will start the first video, because everybody has been very good in preparing a video. I'm also chairing another session somewhere, and it's not been as good. So this is going to be one of the best sessions of the whole IOSSP. Let's get started.
Everyone, my name is Usha Ram and I work as professor in the Department of Biostatistics and Epidemiology at the International Institute for Population Sciences, Mumbai. I shall present key findings on trends in levels and causes of maternal and neonatal mortality in India and for the high and low mortality state clusters from MNH Exemplar Study India. We present our study findings for India as a whole and 2 state clusters. The clusters are identified based on the baseline mortality levels and socioeconomic contexts. These are high mortality, low SES state cluster. There are 9 states in this group and have relatively high neonatal and maternal mortality rate. and lower per capita income. Together, these 9 states comprise of 49% of the country's total population. The second group, known as lower mortality, higher SES state clusters, comprise of the remaining states of India. This group of states have relatively lower mortality and higher per capita income and comprise of 47% of the country's total population. The figure on this slide presents trends in maternal mortality ratios for India and 2 mortality clusters for nearly 2 decades, that is between 2000 and 2017. The SRS in India annually provides estimated level of mortality and fertility data for its states. The SRS estimates indicate that between 2000 and 2017, the maternal mortality ratio for India fell from about 400 to 113 per 100,000 live births. Between 2000 and 2017, the maternal mortality ratio for India reduced at an average rate of 6.3% per year. Regardless of time period, the estimated maternal mortality ratio is notably higher for the high mortality state cluster compared to the low mortality state cluster, that is 161 as against of 73 for 2017, for example. The high mortality state clusters recorded an average annual reduction of 6.2%, while it was 5.9% for the low mortality state cluster. However, during 2012-17, the maternal mortality ratio declined at a much faster pace at an average rate of 8.5% per year in the high mortality states and 6.1% in the low mortality state cluster. Several national and regional studies and multiple data sources have looked at the causes of maternal death in India. However, they lack consistent, strong evidence of changes due to specific causes over time. Empirical evidence suggests that all leading direct causes, including hemorrhage, hypertensive disorders, infections, abortions, intrapartum complications, seem to have declined. Further, the decline seems more for postpartum hemorrhage and less for hypertensive disorders. Population-based studies have indicated that the decline has been more prominent for indirect causes such as anemia, maternal health conditions, and others, with an increase of the median from 15% to 39% in national studies and from 27 to 45% in regional studies before and after 2010, respectively. In the late 1970s, India's neonatal mortality rate was 79 per 1,000 live births. It declined to 45 in 2001 and further to 23 in 2018. Similar to the maternal mortality, the neonatal mortality rate in India has declined considerably over time. However, the pace of decline has varied. The average annual rate of reduction suggests generally faster declines post-2000 compared to the preceding 3 decades. The neonatal mortality rate declined fastest during 2012 to 2017 with an annual reduction of 4.2% per year. On the other hand, the slowest decline was recorded for the period 2006 to 2009 with an annual reduction of 2.58%. The trends in neonatal mortality by state clusters suggest that the rates are converging as the gap between the 2 state clusters is narrowing, especially post-2000. Between 2000 and 2018, the neonatal mortality rate declined from 48.6 to 29 per 1,000 live births among high mortality states and from 35 to 16 among low mortality state cluster. The neonatal mortality rate in 2018 in the high mortality state cluster was the same as in low mortality state cluster 12 years earlier. In 1995, low mortality state clusters had a neonatal mortality rate of 40 per 1,000 live births, which was reached by high mortality states in 2009, a lead of 14 years. The low mortality states have maintained progress at lower levels of NMR. The lead of the low mortality state cluster remained at 12 years at the NMR of 30 per 1,000 live births. The low mortality state cluster achieved it in 2004, and the high mortality state cluster achieved it in 2015. The recent rounds of National Family Health Surveys suggest that decline in mortality rates in all age groups and stillbirths in both high and low mortality state clusters. However, the decline was slowest in day 0-1 deaths. Nationally, only 19% of the neonatal mortality rate decline between the two surveys were due to the decline in 0-1 day mortality. The lack of decline was limited to the high mortality state cluster. About 41% of the decline in neonatal mortality in the low mortality state cluster was due to the decline in 0-1 day mortality. Coming to cause-specific neonatal mortality trends, we present changes in causes of death for neonatal mortality rate from 3 sources, namely Million Death Study, WHO MCEE, and GVD. The findings suggest that the large declines in infections such as pneumonia, asphyxia, birth trauma, and other causes have contributed to the decline in neonatal mortality in India and in both state clusters. With the declining NMR, particularly in the late neonatal period, prematurity and low birth weight contributed an increasing proportion of deaths, particularly as seen in the MDS study, relative to the asphyxia and infections. Further, the cause-specific neonatal mortality rate due to this has not declined notably. This is important despite major reductions in the prevalence of low birth weight and improvements in maternal nutrition. Conversely, mortality due to neonatal infections and particularly lower respiratory infections, tetanus, and diarrhea has decreased markedly between 2000 and 2015-17, although some local studies suggest much higher rates remained. The Global Burden of Disease study estimates indicated most of the decline in infection-related deaths was for lower respiratory infection, which largely occurred in the late neonatal period. Intrapartum causes of neonatal death declined considerably, more so in the MDS. However, the decline is likely to be more modest than what we see for infections because of the slower pace of decline in mortality at 0-1 days than in the late neonatal period. Local studies after 2010 also suggest higher levels of birth asphyxia, trauma mortality, and the high proportion of stillbirths due to intrapartum causes. Comparing two state clusters, there appear to be less declines and possibly some increases, as seen in MDS, in NMR due to prematurity, low birth weight in the high mortality state cluster, but not in the low mortality since 2000. This may be responsible for the lower decline in deaths on day 0-1 relative to the late neonatal mortality seen particularly in the high mortality state cluster. There appeared to be a large decline in the neonatal mortality rate due to infections in both clusters. There was some evidence that this was largely due to a greater decline in lower respiratory infections, which mostly occurs in the late neonatal period, particularly in the high mortality states. Intrapartum causes like birth asphyxia, trauma declined in both state clusters in national studies, but remained important in some regional studies after 2010. Similar to prematurity, low birth weight, birth asphyxia is known to be a major cause of day 0-1 deaths, which had declined in the lower but not high mortality state cluster. Thank you for your kind attention.
Thank you very much, Usha, for that presentation. And I was wondering, I thought all the videos would come at once, but so do we stop here for a second to see if there are any questions? I don't see anything in the chat box for.
I can play the next one. They're just some separated into different videos. So if you'd like me to start the next one, I can do that.
Yeah, I think it'd be good to have the four together, and then we sort of conclude, and then we have a discussion.
All right,
So,
great.
yeah, please go ahead.
So I have one issue, one.
I think we have the slides, but we don't have the sound yet.
Sorry, 1 minute. There was an issue
No
with the
problem.
resolution.
No
I'm
problem.
gonna go back.
Thanks, Usha, and hello, everyone. In this section, we present the changes in the coverage of key MNH interventions, the degree to which these are equitable between socioeconomic groups, and how much it impacted neonatal mortality. In this slide, we present the annual coverage rates for antenatal care, institutional delivery, and ANC with contents for the period 1989 to 2015, using the pooled data from the 3 rounds of district level household survey and 4 rounds of national family health survey, totaling over 1 million births. ANCQ, which is a composite measure with the main components of antenatal care with content and intensity, such as the number of ANC visits, timing of first ANC, skill provider in any ANC, blood pressure, blood sample, urine sample, weight, abdominal examination, and tetanus toxoid. The score ranges from 0 to 13, and in this graph, the trend in the percentage of births that had an ANCQ score of 9+ is shown. All the 3 coverage indicators have increased, converging at high levels in 2011. Any ANC coverage increased fastest during the RCH1 period with an AARC of 3%. Both the coverage of ANC with content and institutional delivery increased at a greater speed during an RHM period of 2005 to 12 at an annual rate of 79%. The coverage increased at a greater speed in higher mortality states, particularly during the RHM period, thus reducing the gap between the 2 state clusters. There was a much sharper increase in institutional delivery and ANC with content in both the clusters, more so in higher mortality state cluster. ANCQ coverage overall was greater in lower mortality states. There was a big increase in public facility deliveries from 2007, especially in community health centers and primary health centers. The increase in private sector deliveries was smaller, although about a quarter of deliveries during 2011-15 were in private sector facilities. Not only did the health facility deliveries increase, there was also a major decline in NMR in facility births. In higher mortality states, there was a major decline in NMR in public health facilities, whereas in lower mortality states, the NMR declined faster in private facilities. In this slide, we present the C-section rate among all births and among institution deliveries in public and private sectors. During the period 2008 to 15, the C-section deliveries doubled from 9% to 18%, and this increase was largely due to the increases in C-section in private sector. In the lower mortality state cluster, C-section rates increased during the 90s and again rose rapidly from 2008 to 11, driven by increases in both private and public sectors. The private sector accounted for about 2/3 of all C-sections. The institutional C-section rate, which is not shown in this graph, was as high as 41% in private facilities and 21% in public facilities. In higher mortality states, C-section rates increased as well, following the increases in institutional birth rates with a few years time lag from 2008 until 2015. The increase was initially driven by a private sector increase, but more recently also by the public sector increase. Nearly 2/3 of C-sections took place in the private sector, which will change over time. Trends in inequalities in coverage by rural-urban residents, maternal education, household wealth, caste, tribe, and religion were examined for any ANC with quality institution delivery and C-section. In general, patterns were similar across indicators and stratifiers, more versus less disadvantaged. And hence, here we focus on delivery coverage trends by urban rural residents and by wealth quintile. Rural institution delivery rates have been increasing since 1990 from 17% to 80% in 2015. The major acceleration occurred during the NRHM period. The C-section rates followed a similar pattern, but the urban-rural gap remained twofold. Rural coverage, however, did reach 14% by 2015, up from 4% in 2000, and in theory, sufficient to meet the need for C-section of all rural women. The time trends by wealth quintiles in this graph show more pronounced inequalities than place of residence or any other characteristic. Institution delivery and C-section coverage among the poorest was still as low as 14% and 2% by 2005, respectively. The corresponding figures in the richest quintile were 86% and 28%. In fact, the C-section rate among the richest was almost twice as high as the institution delivery rate among the poorest. The policy changes during NRHM dramatically changed the situation, with institution delivery rates among the poorest climbing to 66%, while coverage among the richest increased to near universality. The C-section rates also increased in both groups, but still tell a story of extraordinary inequality. 5% among the poorest, still indicative of inadequate access to C-section for the poorest, and no less than 37% among the richest, indicative of heavy overuse of C-section for non-medical reasons. We further analyzed institution delivery coverage by asset ownership and public-private facility in the NFHS 3 and NFHS 4, as shown in this slide. The public facility births increased tremendously in all wealth quintiles except the richest, where the increase was modest. For private facility births, coverage hardly increased in any wealth quintile, and a massive gap between the poorest and the richest persisted. 88% versus 61%. These patterns were observed in both the clusters. Trends in family planning coverage were analyzed in terms of the contraceptive prevalence rate using NFHS 1 to 4 data, as shown in this slide. There was a major increase between 1992, 93, and 2005 in coverage, based on the demand satisfied with modern contraceptive methods in India, from 64% to 72% among currently married women. The gap between both higher and lower mortality state clusters show a steady decline over time, although the gap is still as wide as 19 percentage points, 62% versus 18% by NFHS 4. That's all from me. Thanks, and over to you, Andrea.
Thanks, Ramesh. I think we'll just continue. I think Andrea is ready, so please, can you load up the next video, Ramesh?
Hello, my name is Andrea Blanchard, and I'll be presenting on the health program and service drivers to look more closely at how implementation was strengthened to improve maternal and newborn health intervention coverage and equity, and reduce maternal and neonatal mortality, as we've just been looking at. So one of the important aspects of implementation is to improve availability of maternal and newborn health services at facilities by expanding the availability of these of infrastructure, particularly in the rural areas. So in this slide, it shows the availability of subcenters, primary health centers, and community health centers per million population since the early 1980s for each of the 5-year plans using data from the Rural Health Statistics Report in 2017. So the population used here is the Registrar General and Census Commission of India population projections for single years averaged over the 5-year plan periods. So as you can see in these graphs, the density of subcenters and primary health centers over time, especially since the 90s, hasn't really improved greatly. But for the community health centers, which are larger, there's been a real increase in the density of facilities, particularly since the 90s, and for both the higher mortality states and the lower mortality states in red and green, respectively. Another important aspect of improving the availability and provision of maternal and newborn health services is expanding human resources for health. So on this slide, you see data used on employment from the National Sample Survey Office, data that's representative for India nationally in 2004 and 5 up to 2017-18. The data includes both those who reported being employed as a health worker that did not present qualifications or were self-reported, and those who presented qualifications. So that's presented separately here. And overall, the number of core health professionals increased from around 11 to 15 per 10,000 between 2004-5 and 2017-18, though it's still lower than the recommended 23 per 10,000 in the World Health Report from 2006. The density of nurse midwives specifically went up from around 7 to 10 per 10,000 population, though there were more self-reported than presenting qualifications. And for doctors a bit lower, from about 4 to 6 per 10,000, though this also did go up. And not presented here, but the density of health workers overall was found to be lower in the higher mortality states than in the lower mortality states, even in the more recent NSSO data. Another aspect of improving implementation is reducing out-of-pocket expenditures for maternal and newborn health services, particularly for delivery, and increasing, relatedly, the expansion of Janani Suraksha Yojana incentives for, particularly for institutional delivery. So out-of-pocket expenditure is reduced for antenatal delivery and postnatal services in the public, but not so much the private health centers between 2004 and 2014 in the NSSO data. Out-of-pocket expenditure reduced more for women who were less educated, poor, and of scheduled caste and tribe group, who generally are more disadvantaged. And the receipt of the GSY incentives for institution delivery also increased greatly from around 2006 to 12 in the early NRHM period. And this was more so in the higher mortality states, where there was no conditions on receiving this incentive, compared to lower mortality states where where you had to be of a lower socioeconomic status to receive them. And those who received the incentives were also more likely to have an institutional delivery, and more so in the public facilities, particularly the CHCs and the PHCs, more than the private facilities, which generally hadn't registered for this scheme as much. And while the GSY did not cover all incurred expenses for childbirth, it was widely successful in encouraging families, particularly of the lower socioeconomic status, to opt for public facility deliveries. Another related aspect of increasing the access and use of maternal and newborn health services was the community health worker programs that were brought in, especially under the National Rural Health Mission, or NRHM. And this included notably the accredited social health activists, who were women that were trained within their own villages to provide home visits to pregnant women, among a range of other activities. And coverage of their home visits increased a lot over time, and more for women in the poorer and scheduled caste and tribe groups as well. And more recently, ASHAs were trained in promoting home-based newborn care, which includes counseling on essential newborn care practices, but also providing simpler treatments or referrals for more complicated newborn illness. And the expansion of antenatal care within the village level was brought in through the Village Health and Nutrition Days. This was provided by the auxiliary nurse midwives, or ANMs, with support from other community health workers like ASHAs and Anganwadi workers. And this facilitated birth planning as well, to link the community with health facilities at a higher level to receive delivery and postnatal care. So studies have shown that receiving ASHA and ANM services was linked to higher family planning, antenatal care, and institutional delivery coverage as well in India. Another aspect important in terms of implementation of maternal newborn health care and services is the facility readiness for particularly routine and emergency obstetric and newborn care, which is not as easily studied using trend data or consistent data over time, but we looked at this particularly in research studies. So there's some evidence that in the 1990s, the capacity for emergency services in district hospitals was generally lower. There was an expansion since then in delivery points, which were designated as 24/7 first referral units. And so with that, more primary health centers and community health centers were found to be providing childbirth care in the rural and urban areas. And this is between 2007 and 8 and 2012 and 13, according to the DLHS 3 and 4 data. And there's some evidence that many of these improved more in having emergency drugs and supplies, newborn care equipment, and providing thermal protection, but less so for postpartum hemorrhage management, parenteral magnesium sulfate administration, or assisted vaginal delivery. And so the readiness for emergency obstetric and newborn care also appeared to be lower in more districts of the higher mortality states than the lower mortality states in the last DLHS period of 2012 to 13. And this suggests that the quality of routine and emergency delivery care had improved more and earlier in the low mortality states than the higher mortality states in this later period. And finally, looking at the integration of maternal newborn care services, there's been efforts to really expand the emergency transportation through GPS-fitted ambulances that was scaled up across states over time. And so this was provided for delivery and interfacility transfers or for neonatal illnesses, including integrated call centers and a related incentive scheme more recently. And so call center data from 2013-14, just from 5 states here, showed that the 108 ambulances were used more in rural areas and lower socioeconomic groups. And yet this was still less often used for emergency, obstetric emergencies and interfacility transfers. There was some evidence that more institutional deliveries in the PHCs and CHCs were being referred in a timely manner to a district hospital or medical college at higher levels or private facility for emergency services where they were provided as well. So that's all from me. Thank you so much.
Thank you, Andrea. And so that's let's move on to the last contribution, Gary.
Thank you. I'll be discussing the macro level, contextual, and policy health systems drivers. What did India do to improve maternal and newborn health, and in what context? First, discussing context, we can see modest improvements in poverty reduction and steady improvement in infrastructure and WASH indicators, looking at electricity, access to safe drinking water, access to improved sanitation, and clean fuel. We can see that women's empowerment indicators have generally improved in terms of age at first marriage, literacy, women with secondary or more education, and women's decision-making around a lot of different household issues, including her own access to childcare. The only indicator that did not improve is women's employment, which actually dropped. Mortality declined in all socioeconomic groups, but wealth-related gaps did not reduce. This figure shows neonatal mortality rate for the 5 wealth quintiles, and it looks at national level data, 2005-06 and 2015-16 periods, and you can see the decline, but the persistence of gaps. Similarly, in the lower mortality state clusters and the higher mortality state clusters, decline but persistent gaps. We saw that urban, rural, and by education was the same story. Progress, but no reduction in inequality. Fertility decline contributed about 37% to the reduced number of maternal deaths and 27% to maternal mortality rate reduction. So that 37% comes from combining the yellow 13% with the blue 24% at the bottom, leaving the remaining 63% to some combination of safe motherhood programs. Similarly, for neonatal mortality, we saw fertility declines contributing 44% to the overall reduction in the number of deaths and 27% to the neonatal mortality rate reduction. Now we'll look at the national level policy changes that sought to improve maternal and neonatal health services. The Child Survival and Safe Motherhood Program period has been described as India's shift from an intense focus on family planning to broadening for maternal and child health overall, particularly around maternal anemia and tetanus and childhood immunization. Reproductive and Child Health 1 sought to increase the range of contraceptives available, introduced need-based district-level tailoring to increase program responsiveness, and sought to empower panchayats around some aspects of healthcare. Our Stage 1 also included a major program to train traditional birth attendants for home delivery, and additional human resources were sanctioned, including lady doctors or female medical officers. A range of medicine and supply kits were introduced, as was integrated management of neonatal and childhood illness. RCH2 and the National Rural Health Mission brought an effort to move deliveries from the home to the facility and from traditional birth attendants to skilled birth attendants. The ASHA program was launched, as were Village Health and Nutrition Days. The National Rural Health Mission also introduced contract hiring to fill health worker vacancies, flexible and decentralized financing, including the e-transfer of funds up to the district level to improve disbursement, and the concept of empowered action group states, which are high-need states that receive more intensive inputs and support. Task shifting and multi-skilling sought to bring essential neonatal and maternal health care to rural areas. RCH2 and the National Rural Health Mission also saw the early beginning of special newborn care units in facilities and the initiation of home-based newborn care by ASHAs. Finally, the National Health Mission and RMNCH plus A period introduced a continuum of care approach from community to tertiary facilities and across all life stages, including a 5x5 matrix of high-impact health interventions at these health system levels and across these life stages. This period also brought the introduction of a new maternity benefit and overall showed increased attention to urban health, adolescent health, and nutrition. Here, we zoom in on specific policies related to healthcare around childbirth along the graph of increasing institutional delivery from just 26% of all deliveries in 1990 to 82% by 2015. During CSSM, we saw the introduction of first referral units, which are upgraded community health centers that could provide C-sections and other emergency obstetric care. However, their implementation was quite limited due to a lack of medicine and infrastructure, particularly operating theaters and labor rooms, the unavailability of blood banks, and trouble recruiting specialists like anesthesiologists, obstetricians, and gynecologists. RCH1 brought a new attempt to operationalize FRUs, first referral units, although challenges persisted, especially with recruiting specialists. At the same time, RCH1 initiated a major drive to train traditional birth attendants for safer home deliveries. However, this initiative coincided with growing debate about the value of TBAs. In the early 2000s, FRUs were granted permission to set up blood banks and were issued a set of management and staffing guidelines in a further attempt to improve their functionality. The National Rural Health Mission and RCH2 resolved the debate about TBAs with a clear and coordinated strategy to move deliveries into facilities and into the care of skilled birth attendants. JSY conditional cash transfers incentivized ASHAs and pregnant women to have their babies in healthcare facilities. At the same time, facilities were mandated to improve their capacity with 24-hour service, the advent of Indian public health standards, increased staffing, and increased capacity building among staff. For example, MBBS doctors were trained in life-saving anesthetic skills, and a 21-day skilled birth attendant training program was brought in to increase the capacity of ANMs and staff nurses in many components of BMOC and neonatal care, including the active management of the third stage of labor and neonatal resuscitation. Ambulance services were also strengthened. In recognition that the JSY cash transfer still left families paying out of pocket for a number of services, towards the end of the National Rural Health Mission period, India launched JSSK, which guaranteed free maternal and neonatal care in government facilities, including for C-sections, food, and transportation. The National Health Mission period brought greater attention to training and quality around essential maternal and newborn care, with the launch of National Quality Assurance Standards, revised Indian public health standards, and attention to the human rights of childbearing women. And recently, JSSK was extended to cover antenatal care, postnatal care, and healthcare throughout the first year of a child's life. To summarize, we can see 5 interrelated policy shifts. We saw increasingly comprehensive healthcare with a pro-poor focus. We saw the shift of childbirth from homes and traditional birth attendants to facilities and skilled birth attendants. We saw improving the efforts to improve the availability of healthcare facilities and frontline health worker services, increasing access to evidence-based life-saving technical services in BMONC and CMONC, and efforts to improve the quality of these services. These trajectories were underpinned by changes across all the policy and systems levers of governance, supply chain, regulation, information and communication, with particular advancement in terms of increased financing and health sector reforms to strengthen management and financial planning. Thank you.
So thanks, everyone. I think we've heard 4 very nice, concise presentations. I think now is the point to move to the summary of this and the way forward. And I see Dr. Himanshu Bhushan has arrived. Welcome, Dr. Bhushan. It's great to see you. We've been going through the different presentations, and I think this is the point where we sort of summarize it, and then we would open for discussion.
Thanks, Dr. Tis. Thank you so much, and thanks to all the presenters for beautifully explaining the steps that we took for the national level analysis for the drivers of success in maternal and newborn mortality reduction in India as exemplar in global health. And this very clearly summarizes few key drivers for maternal and neonatal mortality and its reduction at the national level and the factors responsible for it. The first, the 2 exemplar at higher and lower mortality levels with converging declines in MMR and NMR since 2000, higher mortality states, most reduction in deaths between days 2 to 227, while intervention coverage improved greatly by increasing institutional delivery with essential interventions like clean birth and somewhat in emergency obstetric and newborn care, C-sections, etc. Whereas if you see the lower mortality states, reduction in day 0-1 mortality and later in the newborn period, with further increase in institutional delivery coverage with access to emergency obstetric and newborn care, mostly in hospitals, public and private. So at both the places, both in high and mortality states, this has actually the impact was quite visible. Then we also observed the reduced inequalities in service utilization with more rapid gains among less educated, poorer and rural group. You have heard about, shifting of home deliveries to the institutional deliveries, empowering ASAs, empowering, the poor women through increasing access to public sector, giving more transport, more delivery points, JSY incentives, community mobilization by the community health workers, etc. So the inequalities in service utilization also reduced. Then fertility and socio-economic changes was the again major observation, contributed directly to in reduction of the mortality and indirectly by improving health intervention coverage. Sustained fertility declined since 1970s, continuing downward, fastest among lower SES towards replacement level. Whereas these socio-economic changes, especially women's education and empowerment, contributed to reducing mortality risk. So all these two factors are very important for linking fertility and socio-economic changes towards the reduction of maternal and newborn mortality. And then prioritization of maternal and newborn health by the government, because all these changes that you are seeing right now here is by and large mostly contributed because of the earlier National Rural Health Mission, which was launched in 2005, and now it is a National Health Mission, where the broad agenda for targeting MMR and NMR in line with MDGs built in flexibilities for localized evidence-based approaches to expand health financing, human resources, infrastructure. So before National Health Mission, most of the plans were vertical, whereas after the launch of the NRHM, it was based on the needs of the local community and different geographical area. So it was decentralized planning and decentralized things. And National Health Mission and RMNCHM matrix from 2012 put further emphasis on accessibility and quality of care at facility and community level. So in the first few years, we saw that people shifted from the home to the health facility. And then, we also focused here on improving the quality of the care. So all these factors, led for, the reduction of maternal and neonatal mortality. So the national level analysis very clearly, has come out with these evidences. Next, please. So the way forward for it is now in India, NFHS 5 data has been released. So this national level analysis will have to be extended and include NFHS 5 data and see further to analyze where positive trends have continued or accelerated. So if there is any change because of this data and the observations till now, that will be analyzed. Then we will also go down below at the state level, conduct a state level case studies, quantitative data analysis, qualitative document review, key informant interview, and then whatever these data or the outcome of these interviews come, we would synthesize, analyze across the national and state results. And then in the stakeholder meeting, we will take the guidance and the analyze and interpret. And then finally, there will be a dissemination nationally and internationally. So in a way, you can say that national level analysis is the first step that by and large we have completed, but we have already initiated this state level analysis. Then both these analyses will be linked together, further analyze and interpret for the final, dissemination of the nationally and internationally at international level. So this is by and large our thought process and the way forward for this exemplar study. I would also like to place on record my thanks the various partners who are involved, who are supporting this study. NHSRC, from where I represent, it is National Health System Resource Center, a technical support wing of the Ministry of Health and Family Welfare, and also, IIPS, Antarashtriya Jansankhya, Indian Institute of Population Sciences, then which is giving it. In fact, this institute is basically responsible for all the survey data that the country is seeing, the very robust data. Then the Center of Excellence, University of Manitoba, and IHAT, and of course the BMGF support, which is being given to us, along with the countdown to 2030 maternal, newborn, and child survival. I also would like to place on record my thanks to the organizers who have given this opportunity for presenting this, and also all the participants, because any presentation without participants and without the delegates is not successful. So I would like to place on records, thanks to all the presenters, resource persons, participants, delegates, and organizers for giving us this, opportunity on behalf of all the partners who have supported this study. Thank you. So now this forum is open for discussion, any questions. The panel is here, the chairperson is here, we are all here. So we will try to, in the allotted time, answer your questions. Thank you. So Andrea, so kindly see us also in the chat box if any questions are coming, and then please, ask either Tis or anybody to respond for you.
Maybe I could start some discussion, and just want to raise 2 points and see what. And I think it's not just to the panel; it's to everyone who's in the session. But I think first of all, Dr. Mushan, you mentioned NFHS 5, and of course the fact sheets have been released, and I think looking at some of the indicators of neonatal mortality and also coverage of deliveries by institutions, we can already see that the trends were very much continuing after 2015, the NFHS 2015-16 to this 2019-2021 NFHS, which of course is very encouraging. But we have to sort of wait for the full data release to be able to look into whether this age-specific neonatal mortality split that was shown 0 to 1 days and then later mortality, whether that's there still, and also where women deliver. And I think that's something that I wanted to raise as my second point. One of the big debates in maternal and newborn health is around how far can you go with bringing down neonatal and maternal mortality and stillbirth by getting women to deliver in lower level health facilities. And with lower level, I mean below the hospitals. We've seen, and I think the India exemplar is a fantastic example here, because we see that in the higher mortality states on which we were really focused, there's been a dramatic uptake of deliveries in health facilities, and particularly in the lower level public facilities, as was shown, and to some extent in hospitals, but much less so. But one of our big surprises was that actually the lower mortality states, which had already neonatal mortality levels around 20 and maternal mortality levels around just over 100, kept on pushing down mortality over the last 20 years. And this is largely combined with an increase in hospital deliveries. Not in low, there's some increase in lower level health facility deliveries, but it's particularly in hospital deliveries, which are, and institutional deliveries in the lower mortality states in NFHS 5 are about 94 or 95% or so. And we don't know, but we think most of those are in hospitals, like it was in the previous survey. So the big policy question for India, for the lower mortality states, and for many other countries that are in this situation, is how far can you push down maternal mortality and neonatal mortality and stillbirth rates by getting all women to deliver in lower level facilities? Because we know that, unexpected complications happen. In most countries that have, let's say, neonatal mortality rates below 20 or below 15, there are neonatal intensive care units or there's specialized neonatal care available. C-section is comprehensive emergency obstetric care. It's available. So the question, I think, that is a very important one that comes out of this: how far should one go, and should one really start to think in the higher mortality states now about hospital delivery? Sorry, that was a long-winded intervention, but I think it's a really big issue that is so beautifully exposed by this analysis that we now heard of.
So, Dr. Test, can I say a point here, a very important point you have raised? So, I mean, ideally, the participants should respond. I will just take, few seconds just to inform you that, I mean, this is a very, very important analysis. And now India also is taking, slowly moving towards higher health facility, of course, not at the district level, but at the CSC level. So what we are saying in the policy is that NCDs have to come down and the screenings at the primary care level for the NCDs. But when it comes to maternal and newborn care, it should slowly go up. And at present, we are saying up to the CSC level, where we are now doing this advocacy by the midwives. And the midwives are the nurses with enhanced 1.5 years training, and these midwives are to be placed at the CSC and above, so that this gap of complications, which probably we will not be able to timely address at the lower level, will slowly shift towards CHC at sub-district level and the district level. So this shift is taking place slowly, and the importance of Exemplar is that this will strengthen the policy in taking the actions based on for shifting this. Of course, after all the national analysis comes. So I stop here. I encourage more participants to convey their views.
Andrea, there is a question in chat box, please.
Yes, so I was just thinking whether we can segue into that, because I think, thank you. I think, Ram, you've shared some questions around whether you can continue to improve mortality levels or decline them without really improving substantially the nutrition levels of mothers, which is a very good question. Another one is around the birth composition and who is delivering now. So if we know that the fertility rate's really been declining. So if the births are more among older women or maybe if there's any comments or if you wanted to elaborate on the questions, feel free, and we can have a discussion around that as well.
On the nutrition, quickly I can respond that at least in India we are aware to this fact, and we already have initiated with convergence with the other departments, women and child and other departments, Poshan Abhiyan, we call nutrition schemes and program. In fact, tomorrow itself, this is going since last 2 years and more, and tomorrow itself again a special focus is there. We are having a meeting of highest level, the policy makers, that is secretary level meeting, is being organized tomorrow under the chairperson of the Secretary Health for improving nutrition. So the fact that nutrition is a very important contributor for maternal mortality and morbidity is well known. There is no question about it, and that we also fully agree. And we are trying to address this. Not only that, also the anemia, because anemia is a big problem here in our country also.
Maybe Usha or Ramesh, you can explain a little bit about the analysis of the nutrition-related indicators that we've done for the Exemplar.
Yeah, I mean, we looked at thank you, Dr. Ram, for your question. We looked at the, trends in maternal nutrition as well as some aspects of child, size at birth and birth weight. What we saw is that there was an increase definitely in the maternal nutrition in terms of the BMI. But it didn't show a big difference in terms of neonatal mortality. But the child's size at birth and the birth weight, they also have improved over these 2 survey periods, and also have some positive effect on the decline in neonatal mortality that we saw. But you're right that these contextual changes in terms of maternal nutrition as well as intrapartum nutrition is important. But also with the health system improvements, the question is basically that can the health system, interventions can detect early, in terms of maternal nutrition through better antenatal care and identification of, risk pregnancies and, birth preparedness, birth planning, and referring and following it up with the higher facilities like hospital deliveries and things like that probably would be important to look at in the meantime, when the maternal nutrition conditions are also improving. But the recent data shows that anemia levels are not changing much. And in fact, in some of the states, we see worsening condition in terms of maternal anemia. That's true. Over to you, Usha. I don't know if you want to add something.
Thank you, Ramesh. I think you have covered it very nicely, but just to add to what Professor Ram has mentioned about shifting of births to old age, we haven't done that analysis. We certainly can look into that for sure. Because we are doing at the national and these 2 mortality state clusters, so numbers wouldn't be a problem. We can look at it and see what is happening, whether the shifting to the older age is resulting into the reduced pace of decline for that particular age segment. We can do that kind of, and that's a good suggestion actually. We should take that in.
Yeah.
Thank you.
We looked at the age-specific fertility rates also, Usha, right? And
yeah,
it shows that there is kind of, what we call, the things are, closing in the middle ages largely. We see that, right?
No, what probably he meant, is that these 35 plus years births, their share has increased over time. So we could probably compute our mortality rates for these 2 subsegments and see what is happening, which we have so far not done really. So I just take that as a suggestion, and I think we should look into it. And it is possible to do at both these national and sub-cluster level because the numbers wouldn't be an issue. So we can certainly look at for sure. And whatever comes out, we can discuss that. There's a question by Patrick. Yeah. Chat box.
Thanks, Professor Ram. So Patrick, I see a question about, thank you so much for being here as well, and for your, for your appreciation of the session. And I just wanted to ask if we had any response about publishing this in a special journal issue, or what's our plans for as part of, I guess, the dissemination of the work. We have a few other stages of the study that's ongoing, but what are some thoughts on plans for disseminating the national?
I think
we talked about things.
Yeah, I think definitely in the exemplars, as we said earlier, there are 7 countries. So the plan is to have at least one cross-cutting country paper and or one paper that is about what we've learned about MNH transitions and so on, but also about the individual countries. And then for India, I think we definitely feel that there is a lot to say about different analysis, the quantitative and qualitative work. So the plan is indeed to publish this as a special issue at some point in time. I think the very exciting part, of course, is that the NFHS 5 is about to be released, and so we're very up to date in the findings. And I think much of the work that's gone into this in the past year can be extended to this further analysis. I mean, just one additional comment on the nutrition, which I personally was a bit puzzled by why nutrition changes. And as Ramesh said, such a big drop in, say, women who are undernourished as measured by the BMI has occurred from 31 to 21% or so between NFHS 3 and 4. And why didn't that have a major impact on neonatal mortality? And I think that is a bit the same with the anemia story, because they're both very highly prevalent conditions, but the relative risk associated with neonatal mortality is quite modest. So the changes over time don't make a big impact. That said, there may very well be a generational effect of changes in nutrition, as we know, and I think that's been shown in some historical populations in Europe, whereas it takes several generations for nutritional changes to have that positive impact. And of course, what was also seen in the analysis of birth weight data from surveys, which have their limitations, is that at low birth weight, mortality is very high. And that, I think, is one of the big challenges of going ahead. How do you deal with the small and sick newborn? And you need to deal with those if neonatal mortality rates are intended to drop below levels of 15 or even 20. And that's why perhaps hospital care is so crucial as well. I think I see no hands. I see no comments in the chat box. I think maybe Dr. Himanshu, I think we probably ready to close the session, unless there are any last comments from anyone.
So yes, I think that the way the presenters have beautifully explained their points and the methodology of the study and also the outcome, and had also accepted that wherever we need to do more, and probably we will do more, and the points of the state analysis and the way forward, I think it's all is well knitted, and as a result, probably the questions related to this study is not too many. And again, this credit goes to all of you, all the partners, all the people who have very meticulously planned, and as you have shown in the welcome slide, that Ministry of Health in itself has taken interest. They have formed various committees, and finally we have the lowest level implementation committee also, who deliberates every 2 weeks about every aspect. And probably this is the result of those efforts, that probably the study protocols are good. However, we are open to any suggestions at any point of time through email to us, and that will be most welcome suggestion for improving the study. The best part of this study, which I personally feel and I would like to place here on record, is many of the studies which normally the international agencies, international forum or the national forum is being done, is highlighting the odds, the gaps, the problems, what you did not do. But this is the one study who highlights what we did and how those actions that you did has certain positive impacts. This is a great encouragement for all those people who are working in the public health in India, and particularly for those people who are nameless, who are working, silently at the primary care level in form of our ASAs, who are the community health worker, our ANMs who are there, who are never heard of, people do not recognize them, our nurses, our doctors who have always served in the rural area. So this is a big tribute to those silent workers, health workers who have actually contributed in bringing this mortality to a lower level. And India is one of the countries who achieved MDGs for the maternal health because of this effort. So from my side also, I thank all the partners for bringing this positive aspect from the country, which was not possible without your active interventions and with the expertise that you people brought in for this country, for bringing this positive aspect, that what all you did. Even Bihar has, such a, high reduction. UP has such a high reduction, whereas the other parameters in these states are not so good. So this study has highlighted this, and this is one of the best outcome of this study, besides the technical analysis that you are doing. So I stop here, Dr. Tis, and I request you, a chairperson, to kindly, your prerogative to now, if you want, you can close this session. Thank you.
Thank you very much, Dr. Himanshu. I think that, you said it all. I think there are 3 really big characteristics of this kind of study: positive public health, it has been said, and it's embedded into sort of decision-making processes. I think that's another key characteristic. And I especially want to thank Dr. Himanshu for his leadership of the study, because you are connecting us technicians with the policymakers and the Ministry of Health. And I think that is what we're all looking for. I think that, that's how we learn and that's how we gain relevance. So thank you very much for that. I'm looking forward to more work on this in the coming months. And thanks everyone for attending, and have fun at the IOSSP conference. Although I must say it's a strange one. You want to hold people, you want to sort of see your friends, you want to talk in the corridors, meet new people, but we do it this way, and it's still great that we can talk to each other this way. So thank you very much, and see you next time.
Thank you, everyone.
Thank you, everyone. Bye-bye.
Bye.
Thanks. Bye to all of you.
Thank you for all the efforts. Thanks. Thank you.